they are dropping from the bed.
Respond to painful stimuli.
Yep. I mean, stuff typically unexpected. Yeah, no one's expecting to die that day. Every now and then you get people that talk about premonitions, I guess, but for the most part, that is the case. And just a first priority after donning PPE is to determine condition of the patient. Just to touch on the PPE, always be ready out stepping off the truck. I mean, as a driver, you have a little bit extra time because the firefighter's going in, but you don't want to be putting gloves on while looking at the patient that is not breathing. So we want to be able to be ready to go right away. Layperson CPR, greater emphasis on compressions that we talked about, and other than ventilation. Compression only CPR is effective and provides some air movement in and out of the lungs. We definitely do not teach any sort of breathing on people. So the main thing is we want lay people just to start compressions, get that circulation going. Going back to unresponsive patient, you want to start with the CAV. Circulation is more important than airway and breathing. So most responders are certified in CPR to BLS for healthcare providers. Yep. So. It's easy when you walk up to someone, determine consciousness, determine if the patient has a pulse. We talked about that earlier. Check the carotid, check the brachial. You can do radial first. Start compressions with no pulse. It says within 10 seconds. Man, I don't ever search for 10 seconds. 3 at the most. There's no reason to wait the full 10. They'll tell you if they actually have a pulse when you start counting on their chest. And then it notify communication center condition resources needed. I mean, a lot of times if the ambulance isn't there, we might tell them CPR is in progress just so they know to maybe pick it up a little bit or come with lights and sirens. We talked about this a few times. We start with the patient lying on their back on a hard surface. Just don't put them on their face and don't be on the bed. Find correct location to administer compressions. You do not want to do it in the stomach. So you want to find the nipple line and place one hand on top of the other to put your weight on that. And here you have the proper location of a CPR compression. So for adults, with victim on his or her back, tilt the victim's head back to open up his or her airway. We straighten arms and lock elbows. I just get over to try to, because if you're doing it for 2 minutes, it's going to tax you, especially on round 4 of it. So if you lock your elbows and let your weight do it instead of you're doing it with your arms, you can go a lot longer with better quality CPR. And you want to line if you can, it's not always the case. It's easy to see, like on that guy, to line your shoulder directly over your hands, but there have been multiple times where I have, because of everything going on here, like you are doing that and
back of an ambulance.
Yeah, and the back of the ambulance where you're trying to hold one hand up. I mean, it's tough, but it's important to still provide quality CPR. So we're going to press straight down on the chest for 2 to 2.5 inches. And so if you watch it on TV shows or movies, they go maybe a half an inch, if less than maybe that. So it's important to go 2.5 inches and then allow for the chest to recoil, come back before going down again. And when you do that, you're going to feel the ribs break, cartilage. It's a funny feeling the very first 2 compressions. I always just like, here we go. And once you get started, then it's fine. Lift up to release the compression. Like I said, you want to have chest recoil. That allows the heart to fill itself back up with blood, and then you pump in through. It says breathe twice into the victim's mouth while holding the victim's nose every 30 compressions. We're lucky enough here at the fire department, we have a BBM. We'll kind of go over this later, but we have a BBM that you have one person there giving breaths every 6 seconds while someone's doing compressions, and we're not touching anywhere near the mouth with our mouth. So this is for adults. We want to go a rate of 100 to 120 compressions per minute. We continue until the patient starts to begin breathing on their own, regain consciousness. Doesn't happen too often. The main thing, like, you also want to have a firm rhythmic manner. Man, me personally, I just kind of do 1, 2, 3, 4, and just do it over my head, like over and over, and it helps me get through it and keep the same rate and speed and everything. While performing chest compressions, it is often common to hear or feel a patient's rib break due to the pressure. We talked about that. It's very unpleasant. But it's signs of quality. This is something we never want to do, but we have to know how to do. Chest compressions for children. Same thing. Determine consciousness if unresponsive. We check for our pulse at the carotid, brachial. If no pulse, then we move patient to solid surface, just like all the other. With larger children, we can use 2 hands, and then with smaller children, we can use 1. So you have to use your own. If it's a 15-year-old that looks like a 25-year-old, 2 hands is probably fine. But there's been some very small 15-year-old that I think 1 hand would also be fine. So it's not always age appropriate. Same thing, place hand center of the chest. Compress chest about 1/3 of the depth between the chest. So it's about 2 inches with children. Same rate, 100 to 120. Breathe twice into victim's mouth while holding the victim's nose, and then continue until child begins to move, regains consciousness. So it's basically, that part's all the same. We have BVMs for children that we use for them. So again, we don't have to breathe. Now, I feel like if I'm ever outside of work, I would breathe for a child if I had to.
They're in the short list.
Yeah, but not, they are about it. Like I said earlier, adult techniques can be used for larger children. So this is where it gets a little bit different. Chest compressions for infants. Determine patient status, same thing. Most cardiac arrest incidents are for infants that have airway constrictions or obstructions. Kids or infants' airways are super, super small. That's why they're always respiratory sicknesses, it seems like, when you have small children. So we always want to check to make sure that they didn't swallow something that they should have swallowed or something blocking. If you see an obstruction in their mouth, go ahead and remove it if you can. We check for pulse on their brachial. That's the best way. Again, it says 10 seconds to begin compression if you don't have a pulse. Again, I don't wait 10 seconds. I think 3 or 4 or 5 is probably enough. So this is where it gets a lot different. The rates are going to be the same. Your depth is only about 1.5 inches. And then you perform it with index and middle fingers. So you can perform, this is not a child obviously, but you can perform with your 2 fingers pushing down. That keeps you with these 2 fingers from going 2.5 inches compared to like that. So, and just like with all the other stuff, you can continue compressions until infant begins to move, regain consciousness. Is what our ultimate goal is. So, what is the purpose of performing chest compressions during CPR?
Circulate the blood in the body.
Okay. Buckner, what would you do differently for an infant and a child compared to an adult?
The way you place your hand or hands to your chest.
Okay.
2 fingers or 1 hand in your thumb.
Okay. What inches, for a infant, how deep would you go on compressions?
1/3 the distance from the chest to the back, or 2 inches.
I think infant 1.5 inches.
Oh, did you say anything?
Yeah, but that's I know what you meant. You were right there. All right. Now we're going to talk about discontinuing CPR. During it, we usually try to do CPR for at least 20 minutes. It's not our call if we discontinue. Obviously, discontinue if they begin to breathe. But if for us to stop CPR on a patient that never regained pulse, that is not our call. That's a physician. The medic usually makes a call about 20 minutes, and they explain everything to a doctor. And the doctor will make that call. So I'm at least thinking, well, it's not on us to make that decision. Cardiac events are very emotional, especially if patient's family or friends are present, which we try to get them in another room. Doesn't always work that way. I'm also thankful that for the most part, the medics and EMTs take care of talking to the family. We don't have to do that very often, but sometimes our captain will. It has happened, but it's not as common. And just be cognizant, man. You're speaking to someone that just watched a family member die, whether it be someone that they are 85 years old or 55 or 20. Just speak calmly, just like how you want to be treated, with the utmost respect if one of your family or loved ones passed away. Okay, at what point should we just continue CPR?
Physicians always do it, physician director. Or if they regain consciousness.
Regain consciousness, yep. That is good job, guys.
Just easy.
All right. Now we're going to talk about learning objective 7. Describe methods of controlling bleeding. All right. You guys need another break? You say I feel like we're pretty good on breaks. Okay. Blood transports oxygen and nutrients to the cells. Maintaining blood flow and volume is extremely important. Be prepared to control bleeding in victims. These are all things that we do as an EMT, and we actually do fairly control bleeding fairly often. We got lacerations, punctures, abrasions. Abrasions we don't do a whole lot with, and with lacerations and punctures, more so with lacerations, depending on how it looks and if it's bleeding profusely, I might wait so the ambulance can see what it looks like, so they can see how deep it is, just so they know to tell the hospital. But if it is bleeding bad, we got to control it. Then I don't wait for the ambulance to come. I just go ahead and we have different gauze and pads to put over that, and we can wrap it up pretty tightly. And if you need to do multiple ones, we can. Punctures, a lot of time, man, we had one the other day where we had to do a couple different chest seals, and as we're doing, like, we had to open one up so the cops can even get a picture of it before closing it again. So you're usually dealing with something that the cops are involved in with a puncture. Not all the time, but we do chest seals quite a bit with those. Arteries transport blood away from the heart. Blood and arteries are bright red under pressure, so they tend to come out of the body a lot quicker. So they sometimes squirt. The force decreases with significant blood loss, so it will start by coming out a lot, and then it will slowly get less and less, which is not a good sign. They are difficult to control, and these are definitely something you don't want to delay in transporting victims with arterial bleeding to a hospital. Veins move blood back to the heart after it delivers oxygen to the cells. Blood moves through the veins at a slow, steady flow, typically easier to control than arterial bleeding. You'll know the difference between a arterial bleed and a venous bleed. Blood is darker, oxygen has been removed from it. Capillary bleeding, areas between arteries and veins where oxygen nutrients are delivered to the cells, where carbon dioxide and waste are removed by the blood. Blood moves relatively slow. That's more of the oozing, I feel like. Most injuries to the capillaries are scrapes, lacerations more so. That's stuff that we don't deal a whole lot with. There's not a whole lot of blood with those. A lot of times it comes in as uncontrolled bleeding. You get there and it's not even bleeding anymore. So it definitely provides opportunities for infection, which we talked about infection before. So that's not good. What are different types of Weber? Give me some different types of them.
Arterial, venous, capillary.
Can you give me an example of an arterial bleed, Buckner?
Spine has a laceration of the wrist, goes through an artery.
Yeah.
Spur.
The femoral artery is one you don't want to mess with. So hopefully that's not the case. All right. So now we're going to talk about if someone's bleeding, what do we do with that? The different methods that we can do: direct pressure, elevation, or a combination of both. One thing we do quite a bit as a fire department, we put direct pressure on. It's an easy go-to one. So we do that quite a bit. Allows always follow medical protocols and standards of care. Proper PPE, man, we harp on that all the freaking time. Just wear your gloves, wear eye protection. If, I have been involved with blood is squirting out. We don't want to deal with that in our eyes. So wear your gloves, wear your mask, wear your glasses. And we are, it says trained medical professionals use tourniquets to stop blood. That is in our scope of practice. So get good with that. Don't, you just want to get it nice and tight for the bleeding to stop. So we do that quite a bit. Well, not quite a bit, but I have done it a few times. Apply pressure with gloved hand and dressing. We talked about wearing gloves. If the blood soaks through it, this is it's not pretty obvious. Just go ahead and go put another one on. Continue until blood ceases to soak through. Apply bandage to hold dressing in place. So what we do, we get gauze pads, 2 or 3 to stop it, and then we have bandages that we can go around and then make it stay there so we don't have to, it doesn't slip or someone have to continue to hold pressure to it. So the direct pressure with severe bleeding, apply direct pressure with gloved hand immediately. Blood can be lost pretty quickly. Let me take a break. That's true. Blood can be lost quickly, so no time should be wasted. Apply dressing and bandages after they are located and opened. Elevation is used in conjunction with direct pressure when injuries occur to the extremities. This is not the only way to stop the bleeding. You need to have, obviously, go ahead and put a bandage on that and elevate if you can. You can't always elevate, so I would go for the bandages first and direct pressure and then elevation. We talked about those methods that we can use for control external bleeding. Internal bleeding, I feel like is harder for us to deal with. May occur when blood vessels rupture. Space in the body can hold a considerable amount of blood. Had a call where 2 people got shot. The one person with all the blood was fine. The one person with no blood died on scene. So it can be tricky. It's like, man, this guy looks way better than she did. And she's the one talking and screaming, and he is doing nothing. So at that point, you knew, like, I saw 6 holes with no blood coming out, and it's all internal. So not a good day. So signs and symptoms, you'll see significant bruising or other indications of injury, especially involving the patient's torso. That's where a lot of the blood will go, is to the torso. Bleeding from openings such as mouth, nose, or rectum, you will see bloody stool or urine, painful, swollen or rigid abdomen. If you can touch there, you can tell that it's swollen or rigid. It might be full of blood. Internal bleeding, traumatic causes include gunshots, stab wounds, motor vehicle accident or fall. Medical causes include ruptured blood vessels or organs. Uncontrolled internal bleeding is a medical emergency for sure. So we treat patients for shock and immediately transport as quick as we can. What are the signs and symptoms of internal bleeding?
Bruising of the abdomen.
Bruising of the abdomen, that's a good one. That's one of any others out there. Blood, stool, yeah. We're going to talk about shock management now. During shock management, body is unable to regulate itself and maintain normal function. Body is unable to supply enough blood to vital organs to keep them functioning. So there's 3 different types of shock that we deal with here. Hypovolemic. Does anyone know what hypovolemic shock would be?
Also
Lack of blood. Yep. What about neurogenic shock?
injury to the spinal cord.
Cardiogenic. So we got types of shock, causes of shock, trauma, other medical emergencies, anaphylactic shock, and septic shock. Anaphylactic you can see a lot with children, and you hope they have an EpiPen, and then because there's a lot of things that kids may not know they're allergic to until it's too late. So And hypovolemic, going through them, patient loses a substantial amount of blood. Body's unable to supply blood tissue, so the volume of blood is the issue. Majority of shock instances are hypovolemic. On cardiogenic shock, heart is unable to force enough blood tissue for it to function. Lack of supply is the pump issue. And that'd be a heart attack, myocardial infarction, MI. So it's the main cause of heart impairment and can cause cardiogenic shock. On a side note, they use that a lot with death certificates, is MI. If they don't know what the exact cause is, they'll just put MI on it. So, neurogenic shock. Blood vessels expand and contract due to brain signals and regulate the blood flow. Occurs when there's damage to the spinal cord. So it's commonly caused by spinal trauma or head injuries. Anaphylactic shock occurs due to severe allergic reaction. My wife's allergic to walnuts and pecans, but she has them. She's not going to go in anaphylactic shock. She can start to feel her throat kind of feel itchy. She can take Benadryl and be fine.
Yeah, kids good.
So we did find out that Evie has an allergy to dairy so far. We're trying to figure it out but carry an EpiPen just in case.
Yeah. What is so like baked stuff or just drinking it?
Well, she was having issues with being itchy.
She didn't have like
No, like this is like in the last week and a
Well,
half.
it's not the, did you get tested for Volsar?
Yes,
Oh.
they thought it was alpha gal,
yeah.
and it turned out it was everything said, the doctor said it's probably alpha gal.
We have seen Volsars here.
Okay.
I didn't hear about alpha gal until I was in the academy, and now I feel like it's just everywhere.
Well, it's been around for the past like 8-9 years. It's just kind of pretty prevalent now.
So she actually everything she was allergic to was that.
Yeah.
On the little they test you different things, and it turned out
She just
she
has
was
dairy.
negative.
Well,
Which
that's good.
So she can eat meat right now.
Yeah.
So we're just trying to
Just
rule out
cheese,
dairy.
stuff.
Yeah.
Interesting.
But it's never like if she had dairy.
That's good to narrow down though.
Yeah, that's what we're trying to do.
We'll walk bringing cookies over then.
Yeah. Well, now we actually have to pay attention.
Right. None for
So
you.
never had to. Yeah.
Thomas doesn't have that. I thought Thomas had.
Not right now. And septic shock is a result of severe infection. Had CPR on a body that was probably went to septic shock is what the medic said, but she definitely had a lot going on with her skin, so we assumed she was septic. They're not as common as other types, but are still dangerous, especially anaphylactic shock tends to happen with kids, and when something happens to kids, everything gets escalated a little bit more. What are 3 most common types of shocks? You guys did great. We're going to go through the signs and symptoms of shock here, folks. Internal body functions are carefully adjusted to achieve optimal. Negative condition, body adjusts functions accordingly. When your body's in shock, it's just not going to do the normal things. So you're going to have pale, cool, moist skin, rapid heart rate, which is tachycardia, rapid breathing. Nausea. There's a lot of different things. Confusion, dizziness, loss of consciousness. A lot of things that could happen with shock. So what are some signs and symptoms of shock?
Tachycardia.
I know, it's like, okay.
Dizziness,
Way to follow up, yeah.
Alright, so treatment of shock. Patients exhibiting signs and symptoms of shock should be treated immediately and prepared to transport. Paramedic treatment is important but should not delay. There's a lot of times I think that we spend too long on scene and we need to probably get to the hospital quicker, so I think it's important to transport as soon as possible. We keep wounds or injuries elevated like we talked about earlier when possible. Oxygen should be used within local protocols, which we have oxygen, control bleeding. So some of this, like we're talking about the hypovolemic shock, if we can get a tourniquet on, get them some oxygen, cover with blanket to maintain body control. You want try to do all those things, and that's what we do if that's patient goes in the shock. Are there any questions about what we learned? Thank you for your. There'll be a test in just a minute, so we're going to take a little 10-minute break.
Yeah. Well, just me.
How we doing on?
You got 7 minutes left on the battery.
Be a good time to pause?
Yep.
Thanks, Weber.
Yeah. You'll have to stop it and take it off the mounting.